know, we'll be covering depression today. Well done for all of you for turning out on this very sunny Friday, or it's sunny in London anyway. Over the next hour or so, we'll be looking to cover all the high yield points that you need to know for your exams. So right from the pathology through to the different subtypes of depression, the management, the pharmacology, the complications. So hopefully this is sort of a crash course into depression. For those of you who are new, if at any point you have any questions, feel free to post them in the Q&A or in the chat and I will get to them. But depression is a really, really important topic. Not only because so many of your patients will have the condition, but even in your everyday life, I'm sure you'll come across friends and family who suffer from depression. And it's important to be able to recognize it and to not have that negative stigma towards it. Before we jump into things, just remember that we have our question bank, which has several questions on there, and it's a case-based approach. So we typically take you through a case right from first steps through to diagnosis, through to management. So I think it's quite neat. And of course, we have our textbook, and we do have a textbook section on depression. So please do check that out. It will be really useful to consolidate any knowledge gained from this webinar. And if you aren't a premium member, you can use my discount code, which is Shuaib2021, and that will get you something around 20 to 30% off. So please do check that out. Okay, case history. 30-year-old artist has presented with low mood, which has affected her almost every day for the last 8 months. She no longer enjoys painting and spends most of her time indoors. She has low affect, and those are her observations. So just taking that case history, what do we think? Do we think this patient has depression or not? So it's just a yes or no. Do you think they have depression, or do you think they're not depressed based on that clinical presentation? So they've got low mood, and she no longer enjoys painting. She's spending most of her time indoors. So we'll come back to it. But she has essentially her key symptoms are low mood, anhedonia, which is loss of pleasure, and she's becoming a bit socially isolated. She's spending time indoors. So which of the following is a core symptom for the diagnosis of depression? If we pop over to Menti, let's bring it up. So if you go to menti.com and pop in the code at the top, 71712184, then you can access the questions. I've also put the Menti link in the chat. So go to, for those of you who are new here, go to www.menti.com, put in this code at the top when it asks you for it, and you should be able to answer the question. I'll give you all about 30 seconds to do that. So which of the following is a core symptom for the diagnosis of depression? Insomnia, psychomotor agitation, auditory hallucinations, anhedonia, and poor concentration. Let's have a look. Okay, very good. So that's I wasn't expecting all of you to get it right, but you did, so well done. Correct. Anhedonia is a core symptom. Okay, insomnia is an associated symptom, so patients can get sleep disturbance, they can become agitated, they can have poor concentration. These are all associated symptoms. But anhedonia, which means loss of pleasure, they don't find pleasure in everyday activities, that is an essential core symptom. Auditory hallucinations, you don't typically get in depression, that's a feature of psychosis. What are the other core symptoms or symptom? So we have anhedonia, what else? So we have low mood and tiredness. Do we have any other takers? So a lot of you went for low energy. Okay, So we have low energy, low mood, tiredness, I guess, is low energy. All right. So that's where it does get a bit confusing, but we'll come on to that. What is depression? So technically, when we say depression, if we're being proper medics about it, we're talking about major depressive disorder. That's a mood disorder characterized by two core symptoms of low mood and loss of pleasure, or anhedonia. So the two core symptoms are low mood and anhedonia, also known as loss of pleasure. It's common. Okay, so NICE say the prevalence is about 4.5%. I reckon that's probably a bit of an underestimation. WHO, the World Health Organization, say 264 million people are affected worldwide. And quite shockingly, 85% of people in low and middle income countries don't actually receive treatment for their depression because of presumably the culture and the negative stigma attached to it. So it's a serious condition. It's probably underdiagnosed and undertreated, and something that we as young-ish doctors need to take seriously. What are the risk factors? So typically it's more prevalent in older people. It's more common in women. Postpartum as well. So after delivering a baby, women are at risk of postpartum depression. That is different to the baby blues. Baby blues is not a pathological problem. Postpartum depression is and needs treatment. Family history, medications, so the contraceptive pill, again, particularly relevant for women taking the combined pill, corticosteroids, and any previous trauma. So whether that's, childhood abuse, physical abuse, domestic violence, sexual abuse, drug abuse, all of these things contribute towards your mental health and can lead to a state of depression. So the pathophysiology, what is going on? It's not that well understood, but largely you can break it down into three segments: hormonal, genetics, and psychological. So if we have a look at the hormonal side of things first, there is this thing, you may well have come across it in your preclinical years, and that's the monoamine hypothesis. So what this says is that antidepressants cause an increase in our monoamines. Therefore, logic would tell us that depression is down to a lack of monoamines. I think it's quite logical, it makes sense to me. So that's known as the monoamine hypothesis. And what are the monoamines? So what hormones am I talking about when I say a lack of monoamines? Schwabe looks the youngest out of all of us. That's very kind. Dopamine is one. What are the other two? Serotonin, very good. So we've got serotonin, we've got dopamine, and think of the drugs that are used to treat depression. So we've got SSRIs, we've got SNRIs. So what's the N? It's noradrenaline. And interestingly, these different hormones have been linked to different symptoms within depression. So typically lack of dopamine is thought to lead to poor concentration. A lack of noradrenaline is thought to lead to fatigue. A lack of serotonin is thought to lead to physical symptoms. But all you really need to know is that a lack of monoamines contributes to this disease process. The other hormonal implication is the hypothalamus pituitary axis. And dysregulation of this axis is thought to contribute to depression. So this axis involves hormones like cortisol, for example, stress hormones, and dysregulation of this axis contributes to the formation of depression. Genetics, again, depending on what study you look at, but if you look at monozygotic twin-twin concordance studies, the concordance is 50%. So if you are a monozygotic twin and you have depression, there is a 50% chance that your twin will get depression. Okay, so there's a large genetic component to this disease. And of course, there's a large psychological component, all about how, you know, like I said, if there's any abuse that you faced, your upbringing, your behaviors, how your parents treated you, etc. This is all going to impact on your psychology, and that will contribute to depression or your mental state in general. The other thing that I haven't put here are comorbidities. So physical comorbidities, if patients have long-term illnesses like heart failure, like you know, rheumatoid arthritis, these quite debilitating illnesses, of course, this is going to increase your risk of depression. Okay. Which of the following is an organic cause of depression? Back to Menti. I've got hypercholesterolemia. I can't even say small, I can't read it, sorry. Hyponatremia, diabetes, hypothyroidism, or hypoalbuminemia. Okay, so far the questions are far too easy, but don't worry, they will get harder. Hypothyroidism, yes, very good. That is a cause of a reversible cause of depression. So very important, because if the patient has hypothyroidism and they come in with low mood and you don't check their thyroid function and you miss the fact that they're hypothyroid, then you know, you're going to treat them completely incorrectly. Of course, if a patient is has hypothyroidism, you need to give them thyroxine or levothyroxine, and that will improve their mood. You don't necessarily need to give them things like sertraline, etc. So it's really important to recognize organic causes of depression. All the others don't really cause depression. Diabetes, if you're hypoglycemic, that can cause irritability and like mood swings, but diabetes in general doesn't cause a depressive state. Okay, so interestingly, NICE use the DSM-5 criteria, and those are the American criteria, or typically the DSM-5 is used in America. Typically in the UK, we use the ICD-10, but for whatever reason, NICE have chosen the DSM-5 criteria. So they've said, these are the core symptoms and these are the associated symptoms. In order for you to clinically have depression, you need to have 5 of these symptoms. Okay, any of these symptoms, you need to have 5, but at least 1 needs to be a core symptom. Okay, so if you have 5 associated symptoms, you don't have depression. But if you have 1 core symptom and 4 or more associated symptoms, you do have, clinically, you do have depression. Symptoms must be present for 2 weeks. Okay, they must cause functional impairment, so have an impact on their work life, on their family life, etc. They must cause a degree of functional impairment, and they must not be explained by an alternative cause like hypothyroidism, for example. If you meet all of those criteria, you can say your patient clinically has depression. Now, I put loss of energy in bold here because, and as some of you picked up on this earlier, loss of energy is considered a core symptom according to the ICD-10. However, as I'm sure you all know, in the UK, NICE is kind of our go-to guidelines, and NICE have chosen the DSM-5, so we will use the DSM-5. Just to highlight the difference, so ICD-10 have 3 core symptoms of low mood, anhedonia, and loss of energy. And the ICD-10 criteria state you should have at least 2 core symptoms and 4 associated symptoms. Okay, but you don't really need to know that because we use NICE guidelines, and so all you need to know is what's on this slide. In order for a patient to have depression, they should have 5 of the symptoms below. At least 1 needs to be a core symptom. Cool. Fine, so once we've diagnosed our patient with depression, we need to figure out, is this mild, moderate, or severe? If a patient has sub-threshold depression, that means they have less than the 5 symptoms, but they have at least 2 symptoms. Okay, so this is all according to NICE, and this is what you need to know for your exams. If a patient has mild depression, they have the 5 symptoms, but the functional impairment is only minimal. Okay, so they're able to get on with their lives. There's a little bit of functional impairment. Maybe they might be affected slightly at work or whatever it might be, but in general, they can kind of get on with their lives. Then if we go to severe impairment at the other end of the spectrum, sorry, severe depression, that's where the patient has most of the symptoms on that list that I showed you in the previous slide. So we'll have most of those things on that slide: low mood, anhedonia, sleep disturbance, agitation or retardation, poor concentration, suicidal thoughts, worthlessness, guilt, changes in weight, appetite, loss of energy. They'll have most of those symptoms, and they'll have marked functional impairment. So they'll really struggle with everyday life. Plus, they may have psychotic symptoms. Can we name some psychotic symptoms or symptoms of psychosis? Hallucinations, yep. Delusions, exactly, very good. And there's a few others, but delusions, hallucinations, those are 2 very good ones. And we're actually going to go over schizophrenia and psychosis. I think Azim will be covering that in next week's webinar. Moderate is anything in between. Okay, so moderate is just basically between mild and severe. It's important to know this. Okay, so keep this in the back of your mind. And actually, on that note, we'll come on to it in the investigations. I was going to ask, do we know how clinically we can figure out if a patient has mild, moderate, or severe symptoms? But we'll come on to that in a bit. Good. Other subtypes of depression. Again, this is according to NICE and the DSM. So we have this thing called persistent depressive disorder, also known as dysthymia. That's where you have sub-threshold symptoms on most days for at least 2 years. So remember, sub-threshold depression is where you have at least 2 symptoms, but fewer than 5. So if you have that for most days for at least 2 years, you have this condition called dysthymia, or persistent depressive disorder. This is quite a common one that I'm sure we've come across in the news, is seasonal affective disorder. Basically, you get depressed at certain times of the year, usually winter. So every winter or every particular sort of time period, you'll get depressed. It will then go away, and then winter will come back again, and you'll get depressed again. And that's known as seasonal affective disorder. And that kind of makes sense, particularly in the UK in the winter. The nights are quite long and the days are short, and that can kind of predispose people to getting seasonal affective disorder. Premenstrual dysphoric disorder. So this is seen in women, and it's related to menstruation. So symptoms start just before the onset of menstruation, and then they resolve after menstruation. And after about a week or so after the onset of menstruation, the symptoms have pretty much gone away. And then you have depression due to, or depressive disorder due to another medical condition, such as hypothyroidism, or substance-induced or medication-induced depression. And we've already kind of touched on some of the medications that can cause depression. There's a question in the chat. So does having psychotic symptoms with depression automatically make it severe? So that's a good question. Usually that is an indication that the patient has bad or severe depression, but also we need to think as well, there might be overlap with a psychotic condition. We need to think, are the majority of the symptoms depression, or are the majority of the symptoms psychosis? Because then that might change your treatment slightly. But in general, if they're having depressive symptoms with psychosis, you can consider that to be severe depression. I put this in just for interest. You don't need to know this for your exams, but it was something that I was thinking about, is how do you differentiate between grief and depression? Because we're all sad at some point. You know, you may lose a loved one. Some people may have, you know, relationship issues or whatever it might be. And there's a difference between grief and depression. And obviously grief can then transform into depression. So grief is sadness, whereas depression, you have like this protracted, prolonged period of sadness. With grief, the distress relates to the loss, whereas with depression, the distress is kind of there every day in all aspects of life. Grief is more episodic, whereas depression is there in all aspects of your everyday life. And this is according to NICE, but apparently if you're grieving, then your capacity for pleasure is intact, whereas in depression, you lose that capacity for pleasure. With grief, you still maintain your self-worth, whereas with depression, you have this feeling of worthlessness and excessive guilt all the time. And the suicidal thoughts and intention are more severe in depression. So that's kind of the difference. Obviously, there's some overlap. And as I said, grief can eventually transform into depression. Okay. Which of the following questionnaires is used to assess postnatal depression? So they like asking about questionnaires in exams for some reason. So these are the sort of questions you need to get used to. Okay, good. Question still too easy. Edinburgh postnatal depression scale. Most of you got that right. And don't worry if you put the other two answers. They are used in depression, but the Edinburgh postnatal depression scale is specifically used in postnatal depression. I guess it's in the name. Good. So the PHQ-9 is used in depression. The HAD scale is also used in depression and anxiety. The Edinburgh postnatal depression scale is specifically used in postnatal women to screen for postpartum depression. General anxiety disorder 7 is used in anxiety, and the abbreviated mental test is used to look for cognitive impairment in delirium, for example. Okay, so a patient comes to you and you're worried that they have depression. How are you going to investigate this patient? First things first is it's a clinical diagnosis. You don't actually need to do any investigations. The first thing you do is a good history, a good examination, mental state examination, and very, very importantly, you have to assess their suicide risk. If you fail to assess their suicide risk, you have made a big error. You know, that's a negligent thing. If someone comes in with low mood, you need to ask them about suicide. Don't be shy about it. You have to ask them about suicide, because that could potentially, you know, be catastrophic if your patient goes and kills themselves and you haven't asked these specific questions. In general, if a patient does come in with low mood, you almost certainly will carry out some blood tests in reality just to check on the off chance if there's any reversible cause. So you'll do an FBC to check for anemia, because anemia can cause fatigue, and that can sort of mimic certain features of depression. We've already said hypothyroidism is a cause of low mood. If the patient has hypoglycemia, that can cause mood disturbances, and UNEs, just to check their electrolytes. And that's generally what you'll do. NICE also recommend a few other things like liver function tests, etc. But as I said, you're doing these tests just to double check to make sure that there is no reversible cause of their mood issues. Once you've gone past that, you want to do the questionnaires, and you can pick one. You don't have to do all of these. There's the Patient Health Questionnaire 9, Hospital Anxiety and Depression Scale, Beck Depression Inventory, and the Edinburgh Postnatal Depression Scale to look for postpartum depression. NICE recommends all 4 of these. And they're all pretty similar. They basically take you through a bunch of questions, asking things like, do you have the ability to feel pleasure? How have you been feeling over the last X number of days? And they take you through these various questions, and then they give you a score at the end. So the Patient Health Questionnaire, the PHQ 9 questions based on the DSM. Each question is scored from 0 to 3, okay? So you get a max score of 27 at the end. The higher your score, the more severe your depression. The HAD scale is 14 questions. Again, similar vein, it spits out a score at the end. You get a score for depression, and you get a score for anxiety. The higher your score, the more severe your depression, or the more severe your anxiety. Similarly, the Beck Depression Inventory Scale and the Edinburgh Postnatal Depression Scale. And just to give you an insight into what these scores actually mean. So if your score is above 5, you have mild depression. If your score is above 20, you have severe depression, according to the PHQ 9. And if we look at a different scale, like the HAD scale, if your score is 8 to 10, you have mild depression, 15 to 21, moderately to severe depression. So you can pick one of these questionnaires, get the patient to do it, and that will give you an idea as to how severe their depression is. And remember, we can also use this little table here to figure out how severe their depression is. So you can do it clinically, you can use the questionnaires, rule out any reversible causes, and at the end of that process, you will have your diagnosis as to how bad their depression is, essentially. Okay. So I said the key thing you need to do is assess suicide risk. What questions, what's going to make you think that a patient is at higher suicide risk compared to a lower risk patient? i.e., what are the risk factors for suicide? And conversely, what are the protective factors? Do we have any ideas? Risk factors of suicide. So yeah, if they have a previous history of suicide, attempting suicide or self-harm, that's true. Family history, very good. Protective factors, religion and family, yeah, perfect. Male, correct. Good, these are all really good. So now you figured out your patient has depression, they've done the questionnaires, it's not looking, they've done the questionnaires, you've got your diagnosis, you think they have maybe mild, moderate, or severe depression. Now you need to assess their suicide risk. The first couple of questions you need to do just to figure out, are they having suicidal thoughts at all? So, do you have suicidal thoughts? Just be straight with them, be honest and upfront with them. They're there seeing you for a reason. They know, patients know that you're going to have this discussion with them. Do you feel like life is not worth living? Have you attempted suicide in the past? This will give you a general overview of their risk. Once you've done that, you need to figure out, have they made any plans? A lot of patients will say, yeah, occasionally I've had some thoughts about killing myself. But then when you actually ask them about, have they made any plans to kill themselves? They'll say no. And that's very reassuring. The patients who have made plans and are actually enacting those plans, that's where it's really worrying. And you need to think these patients are high risk. So you need to ask them, be straight with them. Have you considered any plans? Have you made a plan to, commit suicide? And then if they have made a plan, you need to figure out how far they've gone into actually carrying out that plan. So have they bought any materials? Have they left a suicide note? Have they tried to conceal their plan from their family? These are all really worrying features. So let me give you an example of a patient I saw when I was on my psychiatry rotation. This is a while back now. It was a man, okay? He was a young man. He was actually quite a high-flying guy. He used to work for a bank or a consultancy, one of these sort of high-flying jobs. And it all started going a bit wrong for him. He left his job, and he was telling me that he was considering suicide. So I was asking him, you know, how far have you got with that? What plans have you put in place? So he told me he had gone as far as buying something called a suicide bag, which is a bag you put over your head, and then you can instill helium into the bag. So the bag's around your head, and it essentially contains a bunch of helium, and that will lead to asphyxiation. And he was properly going into, you know, the intricacies of the plan, why he uses helium in the bag. Because if you use helium, it displaces the carbon dioxide. And obviously, if there's no carbon dioxide in the bag, then you're not going to hyperventilate. You're not going to feel uncomfortable, because the buildup of carbon dioxide is what normally, you know, causes you to start hyperventilating. So he properly thought this through. He told me he's hidden this bag from his parents. So that is like a massive red flag. You know, that's high risk. But then if you have another patient who comes in and says like, yeah, I've had the odd thought of suicide, but, you know, I haven't made any plans, then that isn't high risk, that's low risk, okay? So you need to figure out how serious is this person. And it's hard sometimes because, you know, we're only human. And ultimately, if someone really, really wants to kill themselves, they will hide it from you, and they will tell you, no, I haven't had any plans, and they will leave the consultation and they will go and sadly do it. What else is going to contribute to your formulation of suicide risk is risk factors and protective factors. So males are significantly higher risk of suicide than females. Previous attempts, family history, unemployed, if there's social isolation or they live alone, poor physical health. I think someone said recent breakup. So yeah, if you're recent divorce or whatever it might be, that increases your risk. And then conversely, protective factors. So you ask the patient, you know, is there anything that would stop you from committing suicide? You need to specifically ask them that question. And the two sort of main protective factors usually are religion and family. So the patient will tell you, yeah, you know what, I've got children at home and I would actually never do this. Or a patient might say, actually, it's against my religion, so I wouldn't do it. Those are two recognized protective factors. Good. So where have we got to? We've seen the patient, we've taken a history, we've ruled out reversible causes, we've done our questionnaire, we think this patient has depression, we've assessed their suicide risk. What's the next step? We need to manage them, we need to help them. And someone's asked a great question, what do you do for high risk patients? We'll come on to that. So we've come all this way. Step one in management is if they are high risk, if you're worried that they're going to harm themselves or if they're going to harm others. So harming others is particularly even more relevant when it comes to psychotic disorders, because these patients get hallucinations and delusions, and sometimes they get voices in their head saying they need to, you know, hurt someone else. But regardless, if they're at risk to themselves or others, you need to do something immediately. And it depends on the clinical setting you're in. If you're in the GP practice, if you're in A&E, if you're a policeman on the street, it all depends, but you need to get help immediately. So in the instance where you're in the GP practice, for example, or even if you're an A&E doctor, which all of you will be at some point, you will speak to the on-call mental health service, okay? So in hospital, that's known as the psych liaison service. You'll speak to them, you'll let them know, I've seen this patient, they're at high suicide risk, please come and see them. The psychiatry team will come and see them. If you're in the GP surgery and you're a GP seeing this patient, you will do the same. You'll speak to the mental health team, or you'll ask the patient, please go to A&E immediately. And, you know, that would be kind of the end of that. Where it becomes a bit more problematic is if the patient refuses, because like I said, if patients are genuinely suicidal, they have no interest in speaking to you and kind of sticking around, so they might just try and leave. So in that case, you need to section them under the Mental Health Act, and it depends if you're in a hospital or if you're in a GP surgery or if you're in the community as to what section you'll use. And I've got a kind of a summary of the sections here. But the point is, if the patient is in the GP practice, for example, and you've asked them to go to hospital and they say no, then you need to detain them under the Mental Health Act, if you're worried that they're at a risk to themselves or others. If you're not worried about the risk, and that's fine, you can let them go home, okay? But if you are worried about risk and they're not agreeing to go to hospital or they're not agreeing to admission, you need to section them. And there's various types of sections. So section 2, that's where you admit them for an assessment for 28 days. There's a section 3, and that's where you admit them for treatment for 6 months. There's a section 4, which is an emergency admission for assessment for 72 hours. Section 5.2 is where a ward doctor can detain an inpatient for 72 hours. And then the section 136 is used by the police. So if the police man or woman sees someone acting strangely on the street, they can detain them for 24 hours. And you'll see this in A&E. Patients will come in with the police. The police have detained the patient under section 136. They'll bring them to the hospital. The doctor will then assess the patient to see if they need further assessment or if they can go home. So just running through these sections in a bit more detail. Section 2 and 3 requires 2 doctors, okay? And this is a bit of a time-consuming process. One of those doctors is usually a consultant psychiatrist, and the other maybe a GP or someone else. But the point is, because it needs 2 doctors to sign it off, it can take time. So if you don't have time to faff around finding 2 doctors and this patient needs urgent admission, you can do a section 4, which only requires 1 doctor, and that buys you 72 hours worth of time. If this is a patient already on the ward, so let's say you're on the respiratory ward, you're the F1 on the respiratory ward, and your patient has become acutely suicidal and you're worried that they're at risk to themselves, then as the F1 or the doctor on the ward, you can do this section 5.2. You don't need to be a consultant, and that will allow you to detain the patient for 72 hours. And when I say detain, what I mean is that if they try and leave, security will come and stop them from leaving. And worst case scenario, you can sedate them and kind of put them to sleep essentially. And you're allowed to do that under the Mental Health Act. That's only obviously if there's an immediate risk to self or others. So a patient is diagnosed with mild to moderate depression. Which of the following is first line? So which one needs an AMP? Section 2, Section 3, and Section 4 need an AMP. Section 5.2 does not need an AMP. Neither does Section 136. So patients diagnosed with mild to moderate depression, which of the following is first line? You have intensive CBT, behavioral activation, sertraline, amitriptyline, and computerized CBD. So this is a hard question. Okay, most of you still got it right, so that's good. Computerized CBD. The point I wanted to get here is drugs, medication. We don't just jump to medications, okay? We try and fix the problem with psychotherapy first. I'll come on to all of these in the next slide anyway. So if the patient has mild depression, you can simply just monitor them and follow them up over the period of weeks and see how they get on. If they have mild to moderate depression, or if they have persistent subthreshold depression, so remember this is called dysthymia. That's where you have subthreshold symptoms for at least 2 years. Mild to moderate depression or persistent subthreshold depression. Step 1 is to give them low intensity psychosocial interventions. So that's essentially computerized cognitive behavioral therapy or some form of group therapy, okay? What's the difference between low intensity and high intensity therapies? Low intensity therapies are things like group exercises, computer-based exercises, self-help books, things that the patients can kind of go away and do by themselves. There's not much one-to-one interaction with the specialist. High intensity therapy involves a lot more one-to-one interaction with a therapist, hence it's high intensity. The key point is you don't routinely use antidepressants in mild to moderate depression unless the therapy fails or if they have a previous history of moderate to severe depression, then you can use antidepressants. And again, this is all according to NICE, so it's what you kind of need to know. If they have moderate to severe depression, you use high intensity therapy and antidepressants. High intensity therapy, cognitive behavioral therapy, interpersonal therapy, that's where you discuss the patient's relationships with the people around them, like their friends and family. Behavioral activation is where you discuss methods on how to motivate the patient to do things in life, to get the pleasure back into doing certain things. And couples therapy is, of course, therapy related to couples and improving that relationship. So the key point is antidepressants, we don't routinely use them unless there's evidence of moderate to severe depression or if they've got mild to moderate depression and the psychotherapy hasn't quite worked. Fine, so antidepressants is actually a huge topic. I've tried to distill it and give you the key points. What is the first line? It's an SSRI. So let's go all the way back to pathophysiology, the monoamine hypothesis. Remember, we have a lack of dopamine, serotonin, and noradrenaline. So we need to do something about that. And one of the things we can do is give a selective serotonin reuptake inhibitor. These prevent the reuptake of serotonin at the synapses within the brain. Serotonin levels increase, and that improves depression. Examples include citalopram, sertraline, fluoxetine, and paroxetine. The way you prescribe these is you start off at a low dose and then you slowly titrate up every couple of weeks. Alternatively, if you're worried that the low dose isn't working and you want to try something else, at the 3 to 4 week mark, you can switch to an alternate SSRI. So you start off at a low dose, you titrate it up slowly, or if they're really not improving, you can just switch to a different SSRI. If there's not much response at 6 to 8 weeks, that's when you switch to a second line agent. On average, how quickly do SSRIs work? How quickly do we see the benefit of the SSRIs? So yeah, good. Usually 2 weeks. So at the 2 week mark, you should see some improvement. If not, as I said, you can titrate the dose up or you can switch to an alternative SSRI. And the other key thing I want to point out here is in the initial period, symptoms can get worse, okay? So when you first start a patient on antidepressants, their symptoms can actually get worse before they get better. So it's really important to warn patients, because if you don't, they can just go home and they'll get even more depressed and not know why it's happening. Second line agents are your non-SSRI drugs, so tricyclic antidepressants. serotonin and norepinephrine reuptake inhibitors, also known as SSNRIs, and trazodone. There's a few others like mirtazapine, etc. The point is you only use second line agents if the SSRI has failed. And typically from my clinical experience, you tend to try 2 SSRIs. You never try them at the same time. You know, obviously you don't use 2 antidepressants at once. But what I mean is you try 2 SSRIs separately. If that fails, you'll move on to a second line agent like a tricyclic. If they've got really bad depression, you can add in things like lithium or antipsychotics, which have been shown to help. And if they've got really, really bad depression, life-threatening, severe depression, which isn't responding, you can conduct electroconvulsive therapy. So for those of you who, when you go on your psychiatric rotations, try and go see ECT and find out what it's about. It's yeah, it's basically shock the brain, and it's pretty effective. So does trazodone have a mechanism, or is it beyond us? It does have a mechanism. It's not a tricyclic, it's not an SSNRI, it's not an SSRI. I forgot the exact mechanism through which it works. If someone is smart enough to know, or Google, please do let us know. But it's not a tricyclic or an SSNRI or an SSRI. Yeah. So next thing that they test in exams, and they like to test, is what happens when you stop an antidepressant or switch an antidepressant. So in general, you never stop antidepressants immediately. You take a couple of weeks to taper off the dose, usually 4 weeks. May need longer if the patient has been on long-term therapy. 4 weeks is kind of a ballpark figure. And that's to prevent something called discontinuation syndrome. If you stop an SSRI quickly, or an antidepressant quickly, sorry, patients will get this thing called discontinuation syndrome. They'll get a lot of physical symptoms like abdominal cramps, headache, feeling generally pretty unwell. So to prevent that, you taper the dose slowly. The one exception to the rule, fluoxetine is always an exception. It's, I just think of it in my head as the kind of the rogue antidepressant. You can stop fluoxetine immediately. It has a long half-life, so when you stop it, it kind of remains in the blood for a while. So that's why you don't need to taper the dose. So fluoxetine, remember, it's just a bit rogue. You can stop it immediately. And they may well test that in your exams. That's an SBA favorite. Fine, so what happens with switching to a different SSRI or to a different antidepressant? So if we're switching from one SSRI to another SSRI, you taper the dose of the first SSRI gradually, as we've discussed. So you might taper it over 4 weeks. And then once you've stopped that first SSRI, you start the new SSRI a day after. Okay, so you taper the dose off till you stopped it, and then you start the new SSRI the day after. Again, fluoxetine is always the rogue one. You can stop fluoxetine immediately and start the new SSRI after 4 to 7 days, okay? What if you're switching to a tricyclic, for example? You cross taper. So that means you bring the dose of the SSRI down gradually, and at the same time, you increase the dose of the tricyclic. So the difference being, when you're switching from one SSRI to another SSRI, you taper off and you stop, and then you start the new drug. But when you're going from SSRI to tricyclic, you cross taper. So you bring the dose of the SSRI down gradually, and at the same time, you increase the dose of the tricyclic, okay? Again, fluoxetine is the exception. You just stop it and you start the tricyclic within 4 to 7 days. Another SBA favorite is pregnancy, or more particularly breastfeeding. So this is according to the NICE guidance. In general, you don't really want to put patients who are pregnant on antidepressants because of the risks to the fetus, particularly early on. the literature is not clear, and even NICE say it's not clear as to specifically what those fetal malformations are, but there have been links, so we try and avoid it. You can use an SSRI, a tricyclic, or an SNRI according to NICE if it's a new episode of depression and the patient happens to be pregnant. If they're pregnant and they have established depression and they're already on an antidepressant, you'll aim to stop it where possible, okay? So you'll gradually stop the antidepressant if they've got mild to moderate depression. If they've got moderate depression, then you'll consider stopping it. And if they've got severe depression, you will continue the medication or switch to something which might have a not slightly nicer side effect profile. This is the big one though, breastfeeding depression. The two that are safe, that we generally tend to use, are paroxetine and sertraline. So these are two SSRIs. Which SSRI do we try and avoid in breastfeeding patients? Any ideas? I mean, there's not really many left to choose from. So we've got, yeah, fluoxetine, okay? Generally try and avoid fluoxetine because it's got a long half-life. These have shorter half-lives. NICE also say you can use a tricyclic or an SNRI in breastfeeding patients with caution. But in general, what I've seen in clinical practice is we tend to use paroxetine or sertraline. Yeah, exactly. Remember, fluoxetine is always the rogue one. Okay, this is an interesting question. This is a high yield question. Again, they love asking about side effects of antidepressants. So which of the following increases the risk of serotonin syndrome in a patient on SSRI? We've got paracetamol, amoxicillin, insulin, ibuprofen, and sumatriptan. Okay, still too easy. So sumatriptan, as most of you got right, so well done. Paracetamol is safe, amoxicillin is safe, insulin is safe. Ibuprofen, so with SSRIs, we like to avoid NSAIDs, antiplatelets, and anticoagulants if possible, because there is a reported risk of, or increased risk of, upper GI bleed. Sumatriptan with an SSRI can increase the risk of serotonin syndrome. For those of you who don't know what sumatriptan is, it's a triptan. It's used in migraine treatment. Okay, triptans are used for migraine therapy. Avoid use with an SSRI. Complications. So let's look at the disease-related complications first. Of course, suicide. There are increased morbidity and mortality. So these patients are at higher risk of getting various illnesses, and increased risk of substance abuse, alcohol, recreational drugs, etc. Antidepressant related. So as I said, worsening symptoms in the first few weeks, prolonged QTC. This is really important to know. So classically, the one, antidepressants in general can prolong your QTC, but the classical one is citalopram. Okay, citalopram prolongs the QTC. You must check the ECG. Hypertension, SIADH, syndrome of inappropriate ADH secretion. These patients can become hyponatremic. Discontinuation syndrome, we've already talked about. Patients can get sexual symptoms like erectile dysfunction. Serotonin syndrome with SSRIs, of course. This is a serious condition, must be treated urgently. Patients will present with tachycardia, hyperreflexia, hypertonia, hyperthermia. And as we discussed, there's an increased risk of GI bleeding with SSRIs, and we avoid, therefore, NSAIDs and antiplatelets and anticoagulants. Okay, quick question. We're almost done. Can someone give me some features? How does serotonin syndrome differ from neuroleptic malignant syndrome? Another SVA favorite. Yeah, good. So one of the key ways is serotonin syndrome is hyperreflexic, and neuroleptic malignant syndrome, what's their reflexes? They're hyporeflexic, if I recall correctly. And also, of course, neuroleptic malignant syndrome is related to antipsychotic use, whereas serotonin syndrome is related to SSRIs. So fever, they both get pyrexia, actually. You get fever in both serotonin syndrome and neuroleptic malignant syndrome. Yeah, exactly. So neuroleptic syndrome is due to the dopamine pathways and antipsychotics. Prognosis, 50% of patients recover in 6 months and almost 75% within a year. So that's pretty good, but there's a high risk of recurrence. About 10% of patients will have persistent depression, and quite a sad stat, but 60% of patients who commit suicide have a mood disorder. So depression is something we should take seriously. And just as a further point in terms of treatment, when will you stop the medication? So you'll stop it 6 months, in general, 6 months after they've gone into remission. But if they have really severe depression, you may stop it after a couple of years. So it just depends on how severe their depression was as to how long you continue the medication for. But as a general rule of thumb, at least wait 6 months after remission before stopping that medication. And that is the end of that. Please check out our online textbook, check out my discount code, that'll get you 20 to 30% off. And please do fill out the feedback form. You can access it through the QR code. It's been an absolute pleasure.